In this video, we'll be covering the part 2 of HIV/AIDS by Apurba Sastry. In this, we'll be covering lab diagnosis and post-exposure prophylaxis along with some MCQs. So to start with lab diagnosis, specific test for HIV infection, screening test, antibody detection by ELISA takes 2 to 3 hours, rapid or simple test take less than 30 minutes. Supplemental test, antibody detection, Western blot assay, line immunoassay LIA. Confirmatory test, P24 antigen detection after 12 to 26 days of infection, viral culture by co-cultivation technique. HIV RNA best confirmatory method can be detected 10 to 14 days after the infection. Reverse transcriptase, PCR, RT-PCR, branch DNA assay, NASBA nucleic acid sequence based amplification, real-time RT-PCR for estimating viral load, HIV DNA detection useful for diagnosis of pediatric HIV. Non-specific immunological methods, low CD4 T cell count, hypergammaglobulinemia, neopterin, beta-2 macroglobulin, altered CD4 to CD8 cell ratio. Laboratory diagnosis. Diagnosis of HIV/AIDS is not like other infectious diseases. A number of moral, ethical, legal, and psychosocial issues are associated with a positive HIV status. The disease is lifelong. Outcome is invariably fatal. No cure or vaccine is available so far, and in the majority, the transmission is through sexual contact. Hence, individuals known to be HIV infected are stigmatized and develop a fear of being discriminated and socially outcasted. Therefore, the following care should be taken 3 C's while performing the test for HIV. Consent in written format should be taken before the test is done. The patient should be explained about the nature of the test being performed. Confidentiality of a positive test is a must. Patient name or the word HIV positive should not be written on the report form. Counseling should be provided to motivate the individual to tell the spouse or family and induce behavioral change. Antibody detection. The detection of anti-HIV antibodies is the mainstay of the diagnosis of HIV. The test to detect specific HIV antibodies can be classified into screening assays. Screening assays usually take less time, 2 to 3 hours for ELISA, less than 30 minutes for rapid or simple test. High sensitivity and high specificity. NACO recommends the use of ELISA and rapid kits which have a sensitivity of more than 99.5% and a specificity of more than 98%. Should be confirmed. The results of a single screening test should never be used as the final interpretation of HIV status, as false positive results or technical errors can occur. It is always subjected to confirmatory test. Antigens used for most screening tests are HIV-1 specific P24, GP120, GP160, GP41, and HIV-2 specific GP36. They detect HIV-1 and 2 either separately or together. ELISA, enzyme-linked immunosorbent assay. ELISA is the most commonly performed screening test at the blood banks and tertiary care sites. It is easy to perform, adaptable to a large number of samples. It is sensitive, specific, and cost effective. ELISA kits. Most of the currently available ELISA kits are of two types. Third generation ELISA that uses recombinant and or synthetic peptides as antigen to detect HIV antibodies. Fourth generation ELISA that detects both HIV antibodies and P24 antigen by using combination of recombinant or synthetic peptides as well as monoclonal antibodies respectively. It reduces the window period considerably. Note, older ELISA kits based on crude HIV antigen first generation and recombinant and synthetic antigen second generation are obsolete now. Types of ELISA. Various ELISA formats are in use depending on various different principles like indirect ELISA, competitive ELISA, and sandwich ELISA. First, the rapid or simple test. These assays have been developed for ease of performance and quick results. They generally require less than 30 minutes to perform and do not require special equipment. They are the most commonly used tests in India. They work on various principles such as dot blot assays or immunoconcentration or flow through method. Example, tie-dot test, we'll see in the figure. Immunochromatography or ICT lateral flow assay, particle agglutination assays using latex gelatin RBCs, dipstick comb test, enzyme immune assay based test. So we can see in the figure this is HIV Western blot test strip. Okay. Now coming to supplemental test. These assays are highly specific antibody detection methods, hence used for validation of positive results of screening tests. They are expensive, labor intensive, and need expertise to interpret and may also give equivocal or indeterminate results. Western blot is the most commonly used supplemental test available and is also recommended by NACO. It works on the principle of immunoblot technique. It detects individual antibodies in serum separately against various antigenic fragments of HIV, as we have seen in the figure. Antibody to GAG gene products P55, 40, 24, 18. Antibody to Pol gene products P65, 66, 55, 51, P31. Antibody to N gene products GP120, 160, 41. The antigen antibody complexes appear as distinct bands on nitrocellulose strip. The active results are interpreted as per WHO criteria presence of at least two envelope bands out of GP120, GP160 or GP41 with or without GAG or Pol bands. CTC criteria tens of any two out of P24, GP120, GP160 and GP41 bands. Detection of P24 core antigen. The P24 antigen becomes detectable after 12 to 26 days of infection and lasts for 3 to 4 weeks thereafter. Again, it is elevated during the late advanced stage of AIDS. P24 antigen is detected by 4th generation ELISA described earlier. It is less sensitive, less than approximately 30%, because once the antibody is formed, it binds to the P24 protein and the antigen antibody complex gets eliminated from the blood. Recently, antigen-associated assay has been developed that involves pre-treatment of serum to an agent that liberates P24 antigen from the immunocomplexes. This has shown better sensitivity. Uses of P24 antigen detection test. For confirmation of diagnosis of HIV/AIDS, diagnosis of HIV during the window period, to diagnose the late stage of HIV/AIDS, immune collapse or CNS disease, diagnosis of HIV in infants not reliable, monitoring the progress of HIV infection to resolve equivocal Western blot results. Viral RNA detection. Detection of viral RNA is the gold standard method available for confirmation of HIV diagnosis. Various formats are available targeting Pol and N genes. Reverse transcriptase polymerase chain reaction RT-PCR, transDNA assay, NASPA nucleic acid sequence based amplification, real time RT-PCR for estimating viral load. Apart from the routine diagnosis of HIV, RNA detection has several other uses, such as it is the most sensitive and specific method, detects even few copies of viral RNA and is best method for confirmation of HIV. It's the best tool for diagnosis of HIV during window period, detects HIV earlier than all available methods 10 to 14 days post exposure. Viral load monitoring. Real-time RT-PCR can quantify the viral load and is most appropriate tool for monitoring the response to antiretroviral therapy. Typing. RT-PCR can successfully differentiate between HIV 1 and 2 infections and can detect the specific genotype or subtype. Detection of drug-resistant genes. DNA PCR. PCR detecting proviral DNA is extremely useful for diagnosis of pediatric HIV and to differentiate latent HIV infection from active viral transcription. It is also useful during the window period, viral load estimation, real-time PCR, and detection of genotypes. Isolation of the virus from blood or tissues. Isolation is time-consuming, expensive, takes longer time, 6 weeks or more, and is not sensitive. It is used only for research and not for routine diagnostics. Co-cultivation is the method used for virus isolation. Here, the peripheral blood mononuclear cells (PBMCs) obtained from the patient are co-cultured along with the PBMCs from healthy donor, followed by detection of viral RNA or antigen in culture suspension. Non-specific immunological test. CD4 T cell count. Measurement of CD4 T cell count is carried out by flow cytometry method. It is used for assessing the risk of opportunistic infections, initiation of antiretroviral therapy previously used. Current guideline says treatment should be started in all patients regardless of CD4 T cell count. Monitoring the response to antiretroviral therapy. Abnormal proteins such as neopterin, beta-2 microglobulin and soluble IL-2 receptor are produced by peripheral blood mononuclear cells stimulated by interferon gamma or IL-2, which in turn are produced by HIV-infected Th1 cells. NACO strategy for HIV diagnosis. For the resource-poor countries, it is impracticable to confirm the result of HIV screening test by PCR or Western blot, as these assays are expensive and available only at limited centers. NACO, National AIDS Control Organization India, has formulated a strategic plan for HIV diagnosis. The guidelines are as follows. Depending on the situation or condition for which the test is done, the positive result of first screening test should be either considered as such or confirmed by another one or two screening tests. The first screening test should be highly sensitive, whereas the second and third screening test should have high specificity. The three screening tests should use different principles or different antigens. The same kit should not be used again. Supplemental or confirmatory tests should be used only when the screening test results are equivocal or intermediate. There are four narcostrategic algorithms. Strategy 1. Purpose. It is done for transfusion and transplantation safety, that is, for the screening of blood donors in blood banks. Only one test should be done. If found reactive, then the unit of blood is destroyed. Strategy 2A. Purpose. It is done for sentinel surveillance of HIV infection to estimate the prevalence of infection. UAT. The method followed here is called unlinked anonymous testing, which involves screening of blood specimens taken for purposes other than HIV testing. Then the samples are permanently decoded of personal identifiers. This process occurs without informed consent. Two test format. Positive test of first test should be confirmed by second test. If second test is negative, then it is reported as negative. Strategy 2B. Purpose. It is followed for a diagnosis of HIV/AIDS in symptomatic patients. Positive result for the first test should be confirmed by second test. If the second test is negative, then a third test is done for confirmation. We'll see the figure in a short while. Strategy 3rd. Purpose. It is done for diagnosis of asymptomatic HIV patients, antenatal screening and screening of patients awaiting surgeries. 3 test format. All positive results in the first test should be confirmed by the second and third test. Positive report is sent only if all 3 test results are found reactive. For indeterminate results of strategy 2nd B and 3rd, that is, first test positive but second test or third test is negative, repeat test is done after 14 to 28 days and the sample should be sent to the reference center for the confirmation by Western blot or RT-PCR. So in the figure we can see strategy algorithm 1 for transfusion or transplantation safety. First test is required A1 if positive then consider positive, if negative then consider negative. Second A for surveillance. 2 test kits required. If positive, then perform A2. If both are positive, then report positive. If one is negative, then report negative. And if the initial test is negative, then it is obviously negative. Strategy algorithm 2nd B. Diagnosis of an individual with AIDS indicator disease with symptoms. 2 or 3 test kits required. A1. If negative, then negative. If positive, then perform A2. If both are positive, report positive with post-test counseling. If A1 positive and A2 negative, perform A3. If A1 positive, A2 negative and A3 positive, it is indeterminate. And if A1 positive, A2 and A3 are negative, then report negative. Strategy algorithm 3rd. To detect HIV infection in asymptomatic individuals. 3 test kits required. A1. If A1 negative, then report negative. If A1 positive, then perform A2. If A1, A2 positive, then perform A3. If A1, A2, A3 positive, then report positive with post-test counseling. If A1, A2 positive but A3 negative, then it is indeterminate. Now, if A1 is positive and A2 is negative, then perform A3. If A1, A3 positive, then indeterminate. If A1 positive but A2, A3 negative, then high risk consider indeterminate, low risk consider negative. Now, the prognosis or monitoring of HIV. Various tools available for monitoring the response to antiretroviral therapy include CD4 T cell count, most commonly used, HIV RNA load, most consistent and best tool at present, P24 antigen detection, neopterin and beta 2 macroglobulin level. Note, viral antibody levels are inconsistent and variable during late stage due to immune collapse, hence not reliable for prognosis. Diagnosis of pediatric HIV infection. The routine screening methods, ELISA or rapid simple test, detect IgG antibodies. They cannot differentiate between babies' IgG or maternally transferred IgG, hence cannot be used for diagnosis of pediatric HIV. As all maternal antibodies would disappear by 18 months, therefore IgG assays can be performed after 18 months. Various methods used for diagnosis of pediatric HIV include HIV DNA PCR. This is most recommended method for diagnosis of pediatric HIV. Babies tested for HIV DNA PCR at 6 weeks by DBS, dry blood spot collection. If found positive, then it is reconfirmed by repeat HIV DNA PCR. Then it is reported as positive and the baby is then initiated on lifelong ART. HIV RNA detection, P24 antigen detection, IgG ELISA only after 18 months of age. Diagnosis of HIV in window period. Window period refers to the initial time between the exposure and appearance of detectable levels of antibodies in the serum. The antibodies appear in the blood within 2 to 8 weeks after infection but usually become detectable 3 weeks after 3 weeks to 12 weeks with the assays available presently. It can be as low as 22 days when third generation antibody detection kits with high sensitivity are used. P24 antigen detection. 30% sensitive by 4th generation ELISA. It can be detected by 12 to 16 days after infection. HIV RNA detection by RT-PCR is the best method. It detects HIV RNA around 10 to 14 days after infection. Treatment. Antiretroviral therapy ART. Antiretroviral therapy ART denotes the approved drugs used for treatment of HIV or AIDS. The drugs do not kill all the viruses or cure the disease, however, they have the following goals. Clinical goals: prolongation of life, improvement in quality of life. Virological goals: greatest possible sustained reduction in the viral load. Immunological goals: immune reconstitution, both quantitative and qualitative improvement. Transmission goals: reduction of HIV transmission from the infected person to the others. ART guidelines NACO 2018. Indication to start ART: treat all. That is, ART has to be started in all patients irrespective of CD4 cell count, clinical stage, age, population, or associated OIs. Highly active retroviral therapy HAART. HAART is referred to use of combination of at least 3 antiretroviral drugs to maximally suppress the HIV and stop the progression of disease. Monotherapy with single drug is contraindicated due to inefficiency and chance of development of resistance. NACO recommended antiretroviral first line HAART regime. Principle: NACO recommends to include 3 drugs, 2 NRTIs, NTRTI plus 1 NNRTI as first line regime. Protease inhibitor added to in place of NNRTI for HIV-2 infection. However, the latest regime is TLD regime. Fixed dose combination of tenofovir 300 mg plus lamivudine 300 mg plus dolutegravir 50 mg is the first choice regime. It is given as one tablet once daily. Monitoring: CD4 cell count and viral load have to be monitored every 3 to 6 months to monitor the response to treatment. Opportunistic infections OIs. OIs should be adequately treated with appropriate antimicrobial agents before starting ART. Prophylaxis is indicated for the following OIs: cotrimoxazole preventive therapy CPT for pneumocystis pneumoniae. Okay, the prophylaxis for pneumocystis pneumoniae at dose 800 mg per 160 mg PO once daily may be initiated in the following scenarios. Primary prophylaxis. It is initiated in HIV patient of any condition if CD4 cell count less than 350 cells per cmm or WHO clinical stage 3 and 4. Secondary prophylaxis given to HIV patient with PCP who have completed the treatment and continued until CD4 cell count remains more than 350 cells per cmm for a period of 6 months. Prophylaxis for cryptococcal meningitis. Secondary prophylaxis with fluconazole 200 mg daily should be started for HIV patients with cryptococcal meningitis who have completed treatment and continued until CD4 cell count remains more than 200 cells per cmm for a period of 6 months. There is no role for primary prophylaxis against cryptococcal meningitis. Isoniazid preventive therapy IPT. About 50% of the adults in the community have latent TB infection. Isoniazid protects against progression of latent TB infection into active disease. It also prevents TB reinfection after exposure to an open case of TB. Problem pertaining to use of ART. Although early start of ART can reduce the risk of disease progression, there are many other factors that pose deleterious effects on quality of life. Toxicity and adverse effects of ARTs, especially lipid abnormalities and drug interactions. High risk cost of regime. Risk of development of drug resistance and dissemination of resistance virus. Limited therapeutic options. IRIS, immune reconstitution inflammatory syndrome. It can occur in some cases of AIDS during the recovery phase following the start of ART. As the viral load decreases, the immune system begins to recover, which results in an exaggerated immune response to a previously acquired opportunistic infection, causing an overwhelming inflammatory response that paradoxically makes the symptoms of infection worse. So the antiretroviral drugs are mentioned here. NRTIs are zerovudine, stavudine, lamivudine, didanosine, zalcitabine, abacavir, and etrimicetabine. NTRTI is tenofovir. NNRTI is nivanirapine, if virens, telvirdine, rilpivirine, and itravirine. The PIs or protein inhibitors like sequinavir, ritonavir, nelfinavir, amprinavir, indinavir, lopinavir, fosemprinavir, etazanavir, trepanavir, and darunavir. Okay, others fusion inhibitors, enfuvirtide integrase inhibitors, raltegravir, dolutegravir, elvitegravir, CCR5 receptor inhibitor, maraviroc, pharmacokinetic enhancer, cobicistat. Now the first line ART regime in various situations, code TLE, tenofovir, lamivudine, effervescence in HIV-1 infection in adults, body weight more than 30 kg, ALE, abacavir, limivudine, and effervescence, HIV-1 patient with abnormal serum creatinine values, HIV-1 infection in children, body weight less than 30 kg, TL plus LR, tenofovir, lamivudine, lopinavir, ritonavir, HIV-2 or HIV-1 and HIV-2 co-infection, women received with single dose nevipravine in past pregnancy, post-exposure prophylaxis for healthcare workers. ZLN, zeovidine, lamivudine, nevirapine, and ZLE, zeovidine, lamivudine, effervescence. These old regime, if already initiated earlier, need to be continued on same regime unless failing. Now comes post-exposure prophylaxis. Post-exposure prophylaxis (PEP) is required to reduce the risk of transmission after occupational exposures such as needle stick or sharp injury or mucocutaneous exposure. Every hospital should have a model nodal center for PEP management and must provide PEP free of cost to the employee. TL plus LR regime consists of tenofovir, lamivudine plus lopinavir, ritonavir. Okay. Indication: if the source is unknown or positive for HIV, duration should be started within 2 hours of exposure and continue for 28 days. The advised NACO guideline for post-exposure prophylaxis (PEP) 2018 has been discussed in later chapters. Tenofovir 300 mg, lamivudine 300 mg, 1 tablet once daily, and lopinavir 200 mg plus ritonavir 50 mg, 2 tablets twice daily. NACO guidelines to prevent neonatal HIV. Pregnant women who are found to be HIV reactive are initiated on lifelong ART-TLE regime. Their newborn HIV-exposed babies are initiated on 6 weeks of syrup nevirapine immediately after birth, which may be extended up to 12 weeks if the duration of ART to mother is less than 24 weeks. The baby is also initiated to cotrimoxazole prophylaxis at 6 weeks till 18 months. HIV vaccine strategies, hurdles to jump. After 40 years of discovery of HIV, still medical research failed to invent an effective approved vaccine. This attributes to various factors. High mutability of virus is the most important factor. Long latency between exposure and appearance of symptoms. Lack of ideal small animal models for studying HIV infection. Ethical issues, difficult to get human volunteers. Approaches and trials. The researchers have explored a number of strategies and based on which more than 40 vaccine trials have been conducted in several countries so far. SAV001. It is a killed whole virus vaccine trial going on in Canada from 2012. The vaccine candidate is a genetically modified killed virus by deleting NEF and VPU genes. Efficacy is good, antibody produced till 52 weeks without side effect. Other previously done unsuccessful trials were RV144 trial, VAX10 trial, STEP trial, HVTM505 trial. HIV vaccine trials in India are TGAAC09 trial, modified Vaccinia Ankara MVA trial. In spite of intense research, effort and finance involved, none of the trials have been approved for human use till now. Now coming to the questions, write an essay on a 25-year-old male with history of multiple sex partner admitted with complaints of unexplained fever, progressive loss of weight, persistent diarrhea and generalized lymphadenopathy for the past 6 months. So clearly it is a case study of HIV. We can write the probable diagnosis and the pathogenesis and lab diagnosis. Now the short notes on HIV structure and diagnostic of pediatric HIV we can do. Now come the MCQ. The gene encoding for core of HIV is, it's the GAG gene. During the window period, patient with AIDS is best diagnostic test is RT-PCR. The best indicator for HIV prognosis is HIV RNA. Highest risk of transmission of HIV is through blood products. Okay, so that completes our chapter. In the next chapter, we'll be starting with viral hemorrhagic fever. Okay, so like, share, subscribe. Thanks for watching.